So now I'm like a little bit Justin Bieber or a pop singer, so don't believe me. Just hold on what you already know and follow a little bit the experience. Because lower limbs are, in fact, rather easy. And what I'm doing at home is always evaluating and doing a treatment on causes and not on symptoms. So if you are treating something about lower limb or clinical cases in the lower limb, follow always the causes and not the symptoms. So there are huge differences because I'm treating traumatology, I'm treating sports injuries, I'm doing a lot of those things, and also chronic cases. On each topic we have one particular pathology. If you have any questions about any articulation and about any pathology, ask it. I have my computer with me, and so I can translate everything what you want, or I can give you every topic if you want to. Lower limb is, in fact, when we are starting, it's in fact rather easy because I'm going up till down. And of course you have a lot of pathologies, and you do know the hip and the trochanteric difficulties. When I'm teaching, I'm always looking, and I will, because we have not so much time, I only have 1 hour, and it starts already when you are coming in. So I'm always looking what you're wearing from shoes. Yeah? I'm always looking of how high your heels are. And do you know why you are wearing heels? Do you know? Okay. Do you know why you are wearing heels? Heels. You know? Okay, very good. It's for balancing your hips. It's for seducing. You're a seducing man with that. And normally, when you're doing this, it's for your bum. You're balancing your hips. So don't be astonished if you're wearing high heels that you have hip problems. So your consultation is starting from, no, it's for longer legs and it's for having a nice, for the dress and everything. It's bullshit. It's just for swinging your hips. And the higher it gets, the more you're curving in the back of your spine, the more you have hip problems, the more you have back problems. So if you're starting with something, begin already with the basement. If you are starting already, give your treatment from the beginning on. So hip problems, I'm always looking at the feet also. So if you're going to have a topic about the lower limb, and you want to do the infiltrations about the hip, look at the feet, look at the knee, look at everything. And so it's very important. It starts already with rotations, start already with the shoes. So it's always the same. In the hip problems, we have the complaint from, I can't walk anymore, I have problems. When I'm having a walking distance, it's much slower. So it's less long. It's always the same problem. And you can ask very easy test. Can you stand up? Fine, you did it without any help, without any pushing up and everything. So you do see also for sarcopenia, for muscle weakness and muscle problems. Okay, nice, thank you. I will ask to somebody else. Can you walk up and down? So I'm all. That's very nice. I'm already looking if you're limping, and I'm looking because you're walking a little bit like this. You have small rotation because normally the ladies are making a lot of attention to walk really straight, and sometimes they are walking on a straight line like this. But you didn't. That's good. That's no problem. That's physiological. Okay, fine. Thank you. So it starts already from where I'm going. So as soon I'm starting with the consultation, it's from the waiting room. So trochanteritis, very easy. It's when you are laying down and when you have problems by laying down. And I'm having all those indications, no problem. Look always, I don't know how you're examining people. Are you examining them laying down or sitting? Laying down? Huge problem, don't do it. I will tell you why. If you have obese people in America, there are a lot of obese people, you can't examine them properly. And so, okay, the table is as strong as it is. Normally, if you are sitting, you can do this, and your legs are straight down. If I have something like that, I do know that I already have an anteversion or rotation in my hip. So it gives me other proportions and gives me other problems. Also in traumatology, when you are doing osteosynthesis of the femoral bone and you have done the insuring of your femur, so it can have a lot of problems. So it gives rotational problems. Already, when you have a plaster cast on your leg, what are you doing when you're walking with a plaster cast? You walk like this, with your leg beside. I mean, you keep your foot on the side, and so you're always walking like this. What does that give? Meniscal problems, because you're always giving knee problems on the medial side. And so if you have such a thing, keep always in mind, check the length, check everything, check rotation, check all those little things from the beginning on, because then you can treat the causes and not the symptoms. And if we are talking about bioregulatory medicine, it's always by treating the causes and not the symptoms. Trochanteritis, you have several bursts, and it's easy to infiltrate each one. For me, when you are doing an examination on trochanteritis, it's rather keep it stupid, keep it simple. Just push on it and do think what's underneath. I'm not so smart, so don't be afraid to ask anything. I'm just thinking, when I'm pushing on it, what's underneath? And then I do know how to check it out and how to find it in a proper way, because you can also do infiltrations for trochanteritis and bursitis, but it could be that you have a muscle problem of the gluteus or something else. And those are for other products, because you have all in your little pocket there from Tramil, from the firm heel, everything about the products, but it depends what you're using for, and your technique is a little bit different. So trochanteritis is so easy. Why? You're just looking for it, and when you have it, push, find the sore spot, you prepare your infiltration, and it's spot on. It just infiltrates spot on. And we are infiltrating at a certain degree if you can flex it or whatever. If you can lay it down, it's long needles that I'm using, but I do think that tomorrow we have infiltration techniques, and if you're interested, I can always show you. And when you are eject, for me they are always laying down. They are always laying down because you can use several products. Do you know the products of Heal? I hope so. No? Okay. Just for the easy part. If you have an inflammation, I'm using lymphomycin and Tramil. Why I'm using those products? I'm making a concoction of a cocktail, like a Bloody Mary or a gin tonic. I'm making a cocktail of Tramil and lymphomycin. Tramil because it's regulating the inflammation. It doesn't stop it. It's regulating it, down regulation. It's going by bioregulation. It's down regulation. The lymphomycin is improving the healing aspect and is for draining the inflammation. So that's why I'm using both. Why? Lymphomycin is working on the extracellular matrix, and the Tramil is working on the inflammation cascade. That's why. And what's the opportunity? Because you are high in your cascade, you are really very high. On the T lymphocytes you are. When you're giving an anti-inflammatory drugs, like ibuprofen, Voltaren, those that you know, it's working on lipooxygenase or cyclooxygenase. Those are enzymes who are dealing with the inflammation. The sooner you get in your cascade, the better it is. That's why I'm always doing infiltration technique. An infiltration technique had several advantages. You're spot on, immediately on the spot itself. you can infiltrate without any problems. So when you have, for example, trochanteritis, for technique, infiltration technique, it's very easy. You're laying down, you're turning the leg for looking where it is, and then you can palpate and just feel the sore spot, and you infiltrate spot on the sore spot. So you need some strong hands because you have to turn the leg, otherwise you will not find it properly. And you can infiltrate to the trochanter. Take long needles because you have always a lot of tissue. Do you see enough? Yeah. You have long needles because you have to really go very far or very deep. Even if you want to have at the origin of the muscles, you have to have long needles. So you see that I'm using lymphomycin and Traumel. And why I'm always making a schedule like this, it's the schedule of biopuncture, but it's giving you an idea how many times you have to do it and how deep you have to go. But in fact, how you're writing it down is not so important. That you're writing down your products and where you are infiltrating, that's important. Normally, if you are doing infiltrations for the hip, you can do it for coxarthrosis, you can do it for trochanteritis, you can do it for inflammation, muscle problems. Each time your product changes a little bit. Each time you have to deal with a certain pathway of pathophysiology. So if I'm dealing with osteoarthrosis, I'm using Traumel and Zeal. Okay? So very important, adapt your products. You will see that arthrocele in Chile. You will see that if we have, for example, Traumel, and we are using this, you have a certain cascade and you are slowing down everything. So I do think that in Chile you have some mountains with snow on. If you want to have an avalanche, where you want to be, down or up? Up. You want to be upstream, completely up. Why? Because to stop an avalanche, it's like domino day. You're pushing the first stone and everything is falling. So the sooner I can get in my cascade, the better it is. Basic problem is if you are working with anti-inflammatory drugs, you are stopping on your prostaglandins and you are pushing your leukotrienes too high. And so you are worsening your case, you're worsening your arthrosis, you're worsening everything. So beware that you are working as much upfront as you can. That's the basic principle of it. The lymphomycin is because you are dealing with a lot of tissue repair and we have a nice study on the tail of rats, and it's improving cicatrization and it's improving drainage in the tissues. I think that we have here the study where we have a rat tail, but we have the wound, and here you see it clearly. You see a nice wound healing on that matter. I don't need any words for this because you have a control and you have everything afterwards. And check only the diameter of the tail. And I'm not infiltrating on the spot itself. I'm infiltrating proximal of the pathology. It means that if I have any pathology, what I have to deal with, I'm trying to be upfront and not into. So if, for example, we are talking about Achilles tendon, Achilles tendonitis, or you have carpal tunnel, everybody tries to infiltrate into the carpal tunnel. I don't. I'm infiltrating a little bit proximal of the carpal tunnel, and so you have less problems. For the foot, because it's lower limb, tarsal tunnel you have also. You can infiltrate much more upfront. Why I'm doing or saying this? Because you have also corticoids. You have dipomedrol, diprofos, kenacort, and you have your corticoids. You can use also those, but they have side effects. You can't use them with diabetes, and you have to be very careful to not rupture tendons. For example, if you are doing that nearby tarsal tunnel, or if you are doing that in carpal tunnel, you take risks. If you're looking just to the wound healing and the repair, you do see that there is a huge difference, and it's in an amount of time that is very important, because it's the half of the time that you are improving. So you're working twice as fast. Twice as fast. So it's very important if you're doing this in sports injuries, because the first thing that a sportsman asks is, when can I start again? When do I begin again? When can I run again? Or when can I cycle again? So it's always important to have a certain solution, and you see days after surgery, it's twice as fast. I need the half of the time. And that's just by the regulation of your matrix, by drainage, and by improving cicatrization on behalf of the wound. And so you saw it here very clearly that you have a nice improvement, and not by infiltrating into it, but proximal to it. It's related with the macrophages. You see that you have taken skin samples, and we can give the studies about it. So what we are doing, what we are trying to do is always to prove what we are saying. I'm already working with the product for more than 20 years. So when I'm telling that I'm operating, I have operated 2 hips and 2 knees in 20 years. 2 knees and 2 hips in 20 years. But I'm working for osteoarthrosis and coxarthrosis at least 20 patients a day. So there's a huge difference. So I'm not rich, I'm just driving a Renault, not a Porsche, not a Ferrari, just a Renault. But I have a lot of patients, and they are all happy because I don't need to operate them. If we are talking about osteoarthrosis, we do know that we have always the same problem, walking distance and pain. Always the same. I can't walk, it's swollen, and it hurts like hell. So if we have to deal with those, it's always by or traumatology, overuse syndrome. Often I have patients who had meniscectomy and the meniscus was taken out. It's not so good idea. I'm always looking what I have to do. You can do several radiographs for gonarthrosis. We have different cases if we want to deal with it. But I'm using always, on that matter, Traumeel and Zeal. So I have adapted my product again on behalf of the pathology, because I want to work on the causes and not on the symptoms. And why I'm using Traumeel and Zeal? Because Traumeel, again, is giving a down regulation of the inflammation. In fact, the basic principle do destruction of your for the knee, for cartilage, is that your interleukins, interleukin 1, is much higher, and it's always a vicious circle. It's aggravating always on the same level. And so once you are started with an inflammation who is going by the synovium, it goes on, and it's worsening always, because you have a positive feedback. And what happens, because you have angiogenesis, you have blood vessels are creeping into your cartilage, and when blood vessels are creeping into your cartilage, you have more destruction because you have more weakness, you have more softening of your cartilage, and it gives you huge problems. Can you explain the different degrees of osteoarthrosis? It's very easy. Normally when you have good cartilage, when you are tapping on your knuckle, that has to be the consistency of your cartilage. When you're pushing on your muscle, it's the softening of your cartilage. That's the first degree. The second degree, if you have crab meat, and when you're eating crab and you have crab meat, you have small fibers are coming out of your cartilage. That's the second degree. When you're pulling on them, you have fissures, tears. That's the third degree. And when you are grasping or graving into the fissures, you have a crater. That's the fourth degree. So you can explain easily. And everything depends on which level how big or how great it is and where it's situated. So you have immediately an idea how to deal with. That's why that I'm using Traumeel to downregulate the inflammation, and I'm using Zeal to diminish the neovascularization and to improve on the cartilage consistency itself, and it always improves also my cartilage growth. If you are doing the infiltrations, I'm doing them 3 times. We had done a study, it's called the Mozart study. You have here also a nice little pocket, but it's not a study on itself, it's just post-its, so it's just merchandising. It's better to give the abstract because then you have proof. This is no proof. But if you are giving this in a certain way, so we did it also like hyaluronic acid, because I'm also using hyaluronic acids. So Traumeel, Zeal, very good, but it's not the Holy Grail. It's part of my treatment. It's part of my treatment. Why? Because it's very good in doing the infiltration techniques, and your viscosupplementation with hyaluronic acid, you can even do it with it. You can superpose it. It's not because I'm teaching something that all the rest is bad. That's foolish. That's stupid. That's stupidity. What I'm saying is that if I have a tool which I can hammer a nail into a wall, I can use a hammer or I can use my shoe. It's better to use the hammer. I will give you a tool with the best results and with no side effects and with no complications. If I have older people, gonarthrosis, coxarthrosis, it's always elderly. If I'm using those, I don't have side effects with peptic ulcer. I don't have side effects with stomach. I don't have side effects with diabetes. I don't have side effects with coagulation disorders, because if you are giving a lot of anti-inflammatory drugs, of course, take in consideration the sun, because you have much more sun than I have. So it gives you a lot of side effects. With those, I don't. And if I want to talk about it legally, you have less worries to have with this treatment. Also, you see that we did it 3 times, like in the study of Mozart, and you have an improvement after 4 months. Don't expect that if you are doing the first infiltration, that you have immediately an improvement. That's BS. That's really bullshit. No abbreviations. Why? It's bioregulation. You are regulating down. It's not like that. You are not stopping something. You are regulating something. So it goes slowly down, slowly. And when I'm asking somebody, how did it go? How did you feel? How many % did you improve, or did you have no improvement? I'm always asking how much % do you have an improvement, and how is the improvement? Are you walking better? Have you less pain, or what do you feel? Less swollen? Not everything immediately at once. It's not no pain, no swelling anymore, and I can run 500 miles. That doesn't exist. What you have is, I have better for 20%. I can walk, let's say, 1 kilometer more. I can walk a bigger distance. I can go to the bathroom without cane. So such a thing you will know. Such a thing you will see, but not everything at once. So when you are doing this treatment, always adapt your infiltration technique on behalf of the pathophysiology, on behalf of how to deal or regulate the pathology. We do know that we have everything of osteoarthrosis, and the most part is that we are trying to do it by intra-articular injections. But if you are not used to do intra-articular injections, the basic principle is with hyaluronic acids you have to be into the joint, but with those products you have to be nearby the joint and not always necessarily into it. If we would talk about upper limb and you had the fingers or the toes, it's very painful to do infiltrations there. So you can be nearby. It's much easier. And so because it's working by the synovium, by the synovitis. And when you can lower down your inflammation onto the synovium, you will have a better result. So if you are doing this, you can give a cartilage protection and recovery, and you can also do the regulation and inflammation of the pain. The complete Mozart study is a very nice study. And why do I like it so much? You have a washout and you have less placebo effect than because you did your washout in the beginning. Because you stopped every medication, you checked out if there was already an improvement, and you did a washout of your patients. So those that you are putting in are really very clearly aggravating and having osteoarthrosis. And then you are doing your study as if you would do a viscosupplementation, and you will see that you have also those results. Why I prefer this? Because if you're giving an anti-inflammatory drug, I said it already, you are improving your leukotrienes and you have a more chondrotoxic effect. So it's worsening your case. Don't do it. Again, you have seen that one. I will not do it twice. You know it already. So in the Mozart study, you can have a lot of articles on that one, and the products that we are using is Tramil and Zeal. Is it a good study? Yes, because it's done in different hospitals. We have a long duration date, about 16 weeks per patient. I find it a little bit small, but I do like that we have a big quantity of patients. And the study upset is already washout, then a load in, and then you have randomization and a treatment and a follow-up. The nice part of it is that you are doing it as the same that we're doing with the WOMAC studies and with the hyaluronic acids. And the basic principle that I do find it very important is that you are dividing it very closely. You are doing your first injection on the first day, you're doing your second injection on the 8th, and then your third on the 15th. You are randomizing everything. You are a 3 months follow-up, and on the 3 months follow-up, you will see that we have to deal with a severity score, with pain evaluation, and with the walking distance, like in a WOMAC study. Do you have, first of all, a pain relief? What do you see? You have pain relief. And I'm always asking to my audience, are you really careful? What do you see? Placebo is also giving a relief. Less. Why does it give a relief? Because you have your spacer effect, because you're putting a liquid into the joint, you have a spacer effect. And you have also, for example, cushion, slippery floor. You know when you're on the airport or in the shopping mall and you have a yellow card, and when they have cleaned the floor, cushion, slippery floor, every liquid that you are putting on a smooth surface is giving you problems from gliding. And so in this case, that gives also an improvement of your osteoarthrosis. So it's so easy. Just reflect on it. The basic principle is that, in fact, you need an improvement who is going along, and you see that we have at 99 days a very good improvement. It's really significant, and it has to continue, because when you have your placebo effect with water, because you did it with physiological serum, it will be resorbed and then it will go up again. And I did it, and just for the sake of science, just with 1 and 2 patients, you see that it goes up again. It just goes up again. Your pain and your walking distance is going up again. So pain relief is very important. I'm going in the right way, I hope. Yes. And we have randomization. I think that we had the slides 2 times. And is it a relevant pain relief? It is, because you can really continue. And normally, when you see with the placebo, it stagnates. But in principle, with Tramil and Zeal, it has to improve much more. And then for me, the most important thing is for the patient, the walking distance. can I walk further again? And then you have an improvement of walking distance. And that's basic principle that has to continue. As I said, I'm doing 2 prostheses for the hip and 2 for the knee in 20 years. The difference with my colleagues is that they are doing that every day or at least every week. So there's a huge difference between us both. If I do need to treat, or if I do need to give an example of treatment, I want to be sure that we have no problems, that we have no complications, and that we have no side effects on behalf of all this pathology. And so for the elderly, it's much more better. When I have soccer players or when I have sportsmen, you recognize immediately this. He is not into sports, but you see that it's completely swollen and there is a clear problem with the ankle. And just by doing a lymphomycete infiltration and Traumeel, I am always doing a very good autoregulation, and I have this already after 2 weeks. It's rather important because you are doing your drainage again from the ankle that we are seeing who is very swollen, and you are doing also the regulation of the inflammation reaction on the same level. And so you see that I have adapted always the treatment on behalf of what I'm seeing. Same thing for your Achilles tendon. You can use very easily the infiltrations, and you see there is a little bit swelling here on behalf of the Achilles tendon. And when you can infiltrate into the sheet or nearby the sheet, because you don't need to be into the sheet, you have very good results. Also there, I'm using lymphomycete and Traumeel. You don't have the lymphomycete here, but I think that I can provide it also with a study. And you do have an autoregulation after 3 weeks. Why I'm doing such a treatment? Because due to gastric problems, you have to be always careful. So for elderly, if you want to treat feet or hands, it's very difficult to infiltrate hands. So what are you doing? You're taking the cream. Take Traumeel cream and then gloves. Because the basic principle is that you can put the cream in closed bandage. So other creams can give you skin problems. Traumeel can give you skin problems. So you put the cream on, and then you're putting gloves on, and then you go sleep. So what I'm telling to my patients is, oh, it's very easy. You put the cream on, you put your gloves on, you're doing this. You stand up in the morning and you're putting your gloves on beside your bedpost, and then again in the evening you're putting your cream on, you're putting your gloves on, and I'm telling it like that. They are laughing and they understand it very easily. Basic principle is they don't have any joint problems anymore, and they have a smooth skin. So I'm always gaining, and I don't have any problems. So it's not only the infiltrations, but it's also the cream that I'm using and the ointment, let's say, or the pills. When I'm doing infiltration, I'm often working also with tapes, with dynamic taping. It's not static taping, it's dynamic taping, or tapes who are elastic. And so it provides much more compliance, and it provides much more ease for the patient. So when you are doing such a taping technique, it's very easy because you are avoiding overstretch, overuse, and they can still do sports. So if you have important soccer players, whatever, they are more renowned like Ronaldinho, and we don't have those in Belgium. So it's if you can use those, you will have gaining a lot, and you see the difference in diameter here above. You see them very huge, and if you are taping it, you are assisting your tendon. You are doing your regulation of your technique, and you are having an assistance in the mobility of your tendon. Again, with the same products for down regulation and drainage of always. If you have chronic problems, because it's always very funny and very good if you have acute problems, but you can also use it when you have chronic problems. Why? Because you try to downregulate. What happens if you have a chronic Achilles tendon irritation? You have a growing and creeping in of also a vascularization into your tendon, and it's giving it frailing, it's giving much more swelling. So what happens? Your fibers are like this, close one to each other, and when they are creeping, when the vascularization is creeping in, it's going to do this, and so you have a swollen tendon, less strong, and it can rupture more easily because you have a lot of edema into your tendon. That's why I'm giving those infiltrations to deal with the creeping in of my vascularization, to diminish the edema, and to improve the structure on itself for the Achilles tendon. And if you have a scar, you do know that we can have an improvement on scarring even at a long level or long date. So I start with lymphomiacet and Tramil. Now often I put Zeal into it also. So I'm putting 3 products there, Tramil, Zeal and lymphomiacet. If you do know that Tramil is 2 cc, Zeal is 2 cc and lymphomiacet is 1 cc, you have 5. I'm not using anesthetic, it's not necessary. You can, if you want to be a little bit more for anesthesia, you can do it. It's not necessary, and you're putting different infiltration points along to the tendon, and then you can downregulate the inflammation and improve the cicatrization. Also, for surgery for the rupture of the tendon 7 months before, you do see that there is a swelling. Still painful scar, and he wanted to run again. So the basic principle is just by doing Tramil, and you see that Zeal is just behind the graph. Lymphomiacet, Tramil, Zeal. It didn't swell anymore, and you can run again after 4 weeks and complete autoregulation after 3 months. So when I'm working with those products, what I want to do is that if I'm doing an infiltration on my Achilles tendon, I want to be very careful not to frill it up or not to break it up, because if I would work with corticoids, in 4–6% of the corticoids you have calcifications, and you have also a less good collagen on itself. So you're breaking up a little bit your tendon. So be very careful if you're doing infiltrations with corticoids. Also with heel spur or with plantar fasciitis, you have the same problem, because if you would infiltrate with corticoids, you can have also your impact on the fat path, and then you have much more sore feelings because you have necrosis of your fat path, and so your compression is much higher on that spot, and so you will have problems. You can do your taping technique after you have done your infiltration, and so you are assisting a lot more again on behalf of your fascia and on behalf of your tendon sheets just beneath, and so you can do all your autoregulation again. Infiltration is a straight-on approach. It's easy. You can infiltrate on the spur itself or on the tendon or on the fascia, wherever your sore point is, and so you can give your technique spot on onto it, straight, picking downside. When I'm doing, because those are in my practice room, in fact I'm not using gloves. If it would be for legal reasons, or if I have to show it in America, I'm wearing gloves, and I'm wearing a little bit more with, but if you have a proper technique, there is no need for, and you can do it like that. So also here you have lymphomiacet, Tramil, and you have a very good same treatment and stabilization after a few months. I do know that I was a little bit fast because I want to be in time for having everything rather done, because I think that you are scheduled till 10 o'clock. So I'm a little bit up front, so I have still let's say, 10 minutes to answer all your questions. So be my guest. The more, the merrier, and the more, the better. Don't say that there aren't any questions.
Are you using echographic guidance or just anatomic guidance for your infiltrations? If are you using echographic guidance?
Yeah, wait. Sorry, repeat the question. You can. You can improves, but it's not necessary. It's not obligated, because when you're pushing and you're really finding very clearly where you want to infiltrate, you don't need the guidance. If you are not sure, for example, if you want to be into the tendon sheet for Achilles tendon, it's a good thing. It's a very good thing, but it's not necessary. So it's a tool, but if, for example, a general practitioner want to infiltrate, it's not obligated to use echography or guided by echography. It's not necessary. So you can use it without.
¿Alguien quiere una otra pregunta? ¿No? Yo le voy a hacer una pregunta. Acá hay.
Tengo una pregunta. He escuchado de otras personas que han hecho charlas con fármacos bioreguladores que tienen la opinión de no mezclar distintos bioreguladores en la misma jeringa. Y si necesito tener el efecto del linfomiosot, Traumel o Artrocel, es mejor hacerlo en diferentes tiempos. ¿Qué piensa usted al respecto? ¿Es realmente así?
I do understand your question. And I do know that, for example, Jan Kerschot in the beginning has said also to do it at different times, because you want to first do the drainage phase and then the immune modulation phase, and then that's true. But, for example, if you can do that with a hyper-reactor, somebody who is reacting very, very forcefully on what you're doing, how can you see that? You can see that if you are taking an alcohol swab and you are rubbing the skin and the skin is already very reddish, you do know that you have a hyperreactor. You do know that you have somebody who is reacting very hard on every product that you will put on. So there, use one product if you want to be on the safe side, let's say. Otherwise, in general, I'm combining. Why I'm combining? Because they are assisting each other. They are helping each other. And so you have a better effect. I do know that Jan Kerschot, because I saw him Friday, so we are on good terms on that. So if it is a hyperreactor, just do it separately. If you want to have a faster effect or a little bit more improvement on your physiopathological way, like we did in the Mozart study, do it in combinations. But reflect on what you're using. Because we could say biopuncture and bioregulation, it's very easy, and so it's the holy grail. That's not. You have to reflect what you will give on the pathway, on the pathophysiological way, because you have to reflect how the cause or how the origin has been giving that pathology. And if you do know that, you can take the products that you consider necessary to deal with the pathophysiology of, and so it's better to do than the combinations, because you will go a little bit faster. If you're doing it separately, you may, but then you are shortening your infiltration moment. For example, if you're doing it separately, you can, what I'm doing is every week. So you come on Monday, and next Monday I will see you again. If you're doing it a separate technique, you can do, for example, Monday, Friday, Monday, Friday, Monday, Friday. So then you are seeing your patient sooner, and you are doing your technique a little bit in a different way. But then you are seeing your patient sooner in the infiltrations.
Quería agregar un comentario. En Chile en general usamos siempre combinado. También eso lo dice a veces el doctor Arturo Virne, porque él tiene una visión un poco más, que ya está de acuerdo con nosotros en realidad, que combinar no hay ningún problema. Se decía que por un problema que tú tenías que poner una cierta cantidad de antígenos, pero la verdad es que nuestro sistema inmune está capacitado para recibir cualquier cantidad de diferente información. Entonces no tiene ningún sentido separarlos, la verdad. ¿Alguna otra pregunta?
En el caso de las patologías degenerativas que sabemos que no se van a mejorar, estos, por ejemplo, cada 3 semanas, cada cuánto tiempo o entre medio de un ciclo y otro ciclo usas algún tipo de fármacos orales?
First of all, why are you saying that they are not improving anymore?
Porque, como bien decía, esto va a disminuir durante un tiempo, pero no vamos a lograr evitar que en el transcurso de la vida siga aumentando.
Yeah, I do know, and I understand your question, no problem. Never consider that everything is always for degenerative or worsening. What you want to try is to stop everything and stop that you are deteriorating and that you are aggravating progressively more and more. So for that reason, we have one medication which with HALE, but you do need to do other things beside. So, like I said, think, reflect. It's not the Holy Grail, it's not the holy water, but it's a very good tool that I'm using to help me to deal with every pathology, because when I'm dealing, I'm always giving the nutrients, I'm doing on phyto, I'm doing really on nutrition, I'm working on the weight loss, I'm working on mobility, because mobility is very important. I'm giving them ergonomic rules, I'm giving them an improvement. But the basic principle is why I'm using bioregulation, because without any side effects, I can do it on long term. When I want to deal or treatment, or when I'm going to deal with a degenerative pathology, like you are saying, and that you are going out of worsening for the rest of my life, so I have to deal on long term. If I'm giving anti-inflammatory drugs on long term, I will have kidney problems and liver problems. If I'm doing that on a bioregulatory way, I don't have those problems anymore. That's basic principle number one. I can do it on long term. The second point that I want to make is that you are treating the cause and not the symptoms. So you are lowering down the aggravation. Before you are doing that, you have to do this for several repetitional periods. And that's your second question, because, of course, you can do a treatment, and you can repeat your treatment with an interval of 3 months, 6 months, or 1 year. It depends a little bit on the complaints of your patient. So if I have a patient and I'm doing a treatment, what do I see? That if my treatment is succeeding, I never have to complain with my patient, because my patients do see that it's going well for them, and they continue themselves because they see the difference. I have a lot of patients, not because I'm making publicity, because it's prohibited in Belgium. You may not have any publicity out. The only basic principle is we are calling it the public radio, because people are talking. People are talking. You have to go to that guy because he doesn't operate, and I was still doing my thing, and I'm going well, and I can play tennis again. Oh, and you see Papi running on the field, and that's my publication, because you see the difference. I don't have to complain with my patients, but I see them every month when it's going well. I see them every 3 months. And so I'm going to look every 3 months how they are doing. If they are doing well, I don't do anything more. If I see there is a little bit swelling or aggravation or inflammation again, I'm redoing my treatment. I'm restarting my treatment, but often just in an oral way, not in an injectory or an infiltration way. If I see
after 1 year everything is going well, because with the interval of 3 months I'm doing the evaluation. But I don't have any problems with that, because my patients just do it because they see the difference. I don't have to convince them. If you have to convince your patient at the end of your treatment, you did a wrong treatment. If you don't need to convince your patient after your treatment, you are a good doctor, because he will follow you wherever you go. So that's no problem. But in fact, you are down-regulating, you are stopping side effects, you are stopping complaints, and you are checking out every 3 months. That's the short version of the answer.
¿Alguna otra pregunta? Yo quería preguntar, en el caso de una tendinitis de Aquiles crónica, ¿cada cuánto tiempo la tratas? ¿Por cuánto tiempo?
Normally you have already an improvement after 3 or 4 times, but you need at least...
¿Cada cuánto tiempo trata? ¿Una a la semana?
You have, because if I'm treating that 3 to 4 times, it means already 1 month, because I'm with an interval of 1 week. If it's really a huge soccer player, I'm doing it 2 or 3 times in a week. It depends how professional they are. If they are very professional, they want to go very fast, so I'm doing it 3 times in a week. So I'm doing it on Monday, Wednesday and Friday, and then in the weekend they are gone. Monday, Wednesday, Friday. If it's just the second division, I'm doing it on Monday and Thursday. If it's just ordinary people, I'm doing it on whatever day, and I'm seeing them 1 week later. So it's very easy. But when you're doing this, it always depends on the reaction, because when I'm doing with very important soccer players, I do the taping technique, and I'm doing it twice, the taping, for giving them more stability and more assistance for the Achilles tendon. If it's just somebody who is working on a desk and even don't need to do the taping technique, and I can leave it as it is, and they're working with the Tramil cream onto the Achilles tendon itself. So there I'm saying, put the cream on closed bandage, so a lot of cream, bandage, you put your socks on and you go to sleep, always the same. Why do I'm doing always go sleeping? Because when you're rubbing it in, you have the half of your fingers, the half on the sheets, and the rest you're washing off, and so you have just 10 or 20% of the cream on the lesion. So I'm putting a lot of cream, just bandage, put your socks on, go to sleep, don't rub it in, leave it as it is, and in the morning you're doing the rubbing in. The remaining you're rubbing it in. And normally you have already an improvement after, and you have your regulation after 1 month, but even for chronic tendonitis. But look at it, because if you have shoes who are rubbing against tendon, it's bad. If you have, those people are wearing high heels, so look always at the causes. Why do you have that chronic Achilles tendonitis? It's easy, but you need one month.
Okay. Muchas gracias, doctor Deneweth, por esta excelente charla. La verdad es que acá en Chile, tanto acá como, por ejemplo, en la clínica Indisa, la doctora Paola Ritter utiliza muchos medicamentos en todas estas patologías de lesiones musculoesqueléticas. Yo sé que acá la doctora Jessica Castillo, la gente de fisiatría también, la clínica alemana también, o sea, realmente funcionan y están andando súper bien. Lo que les quiero decir, si quieren ver el estudio completo del linfomiosot o el estudio completo del estudio Mozart, lo tenemos, por favor pídanselo al representante y se los pueden hacer llegar, si los quieren completo. Muchas gracias, doctora Castillo, por darnos esta oportunidad.